Presents with end-stage renal disease due to type 1. A 50-year-old male presents with end-stage renal disease due to type 1 diabetes mellitus, polyneuropathy, and coronary artery disease. He is scheduled for a cadaveric renal transplant. He is dialyzed twice per week, and his last dialysis was 3 days ago. His hemoglobin is 8, and potassium is 6 milliequivalents per liter. What are your anesthetic concerns in this patient?
The patient may have taken an ACE inhibitor or angiotensin receptor blocker, have electrolyte abnormalities in addition to his hyperkalemia, be acidotic or volume overloaded.
How do you estimate the volume status of the patient?
In addition to physical exam, it can be estimated from the frequency of dialysis and the last time that it was performed. A comparison to the patient's dry weight may also be useful. This patient may be volume overloaded given 3 days since his last dialysis.
Would you transfuse at a hemoglobin of 8?
I would not transfuse an asymptomatic patient at a hemoglobin of 8. There is an increased risk of acute graft rejection with transfusion.
How would you induce this patient, and why?
I would likely perform a rapid sequence induction with rocuronium and propofol. The patient is diabetic, so he may have gastroparesis, and he also may not be MPO for this urgent operation.
Would you use sevoflurane for a kidney transplant?
Yes, I would use sevoflurane. I would keep the flow higher than 2 liters per minute to avoid the potential for compound A production. Compound A formation from the reaction of sevoflurane with CO2 absorbent has been shown to cause kidney injury in animals, but not humans.
The patient is bleeding more than expected. What are the potential causes?
Excessive bleeding could be due to hypothermia, uremic coagulopathy, severe anemia, inadequate surgical hemostasis, thrombocytopenia, or metabolic acidosis.
What causes uremic coagulopathy?
Uremia interferes with the platelet aggregation and adhesiveness. The exact mechanism is unknown, but uremic toxins and increased nitric oxide production may play a role.
How do you treat uremic coagulopathy?
Dialysis and DDAVP would be my first choice in treatment. Other treatments include correction of anemia and cryoprecipitate. Conjugated estrogens can be used for chronic treatment.
The patient is oliguric post-op. What is your differential?
The cause of postoperative oliguria include hypovolemia, hypotension, acute graft rejection, renal artery or vein thrombosis, ATN, mechanical obstruction of the graft vessels or ureter, and obstruction of the Foley catheter.